And we move on to the next talk. Ramesh, cutting edge technology is the topic. Yeah. So basically, Ramesh, I think you have to go that side. Yeah. So basically, the ESRS calculator, which was launched the year before last, is very effective. Like if you want to compare multiple formulas, not all formulas are integrated there. Whatever formulas are integrated, they give you in one screen. What are the...
It's not moving.
Yeah. So earlier on, we used to go to each website, take printouts and compare. So that has become a very useful boon for most of us. So over to you, Ramesh.
Can you get me a pointer, please? So this message came in the EWS group sometime back. Please advise, I performed an uneventful phaco with a multifocal IOL 20 days ago, but the patient came back with around 0.75 to 1. Patient is not happy. What is the best option? This question came up. Now, this is something that we all face if you are aiming for plano. We should realize that Douglas Koch in last year's CRST, cataract and refractive surgery times in 2023 said that 90% to 92+% is probably our ceiling. Patients must be informed that they have a 1 in 10 to 1 in 20 chance of having a residual refractive error. Let us accept this. There will be some of our patients with a residual refractive error. My talk is on... Thank you so much. Thank you. My talk is on high-tech solutions for calculating the intraocular power. So there are low-cost solutions which is applicable to all, wherever we practice, whether in a small village or in a small clinic. And we have high-cost solutions which is more applicable if you're in a corporate setup. So we can use cutting-edge tech which are low-cost everywhere because it is online and it is free. Dr. Arup had mentioned about the importance of corneal power. This is very, very important, and because axial length measurement is no longer the key, we have to improve measurements of the cornea. The low-cost, high-tech way of doing this is to use warm compress for at least 1 minute, and ideally for 10 minutes daily for a week or two before you take your K, followed by gentle cleansing with a baby soap so that it doesn't burn the patient. You can do this and put artificial tears. This is a low-tech way. The high-cost, this is a low-cost, high-tech way. This is the high-cost, high-tech way. The costly way is to use microblepharoexfoliations, derm abrasion machines, IPL, and LipiFlow, and equipment like that to improve the tear film. Axial length is the next most important measurement, and as Dr. Arup clearly told us, all optical biometers will give you the same very good axial length measurement. The importance of using an SSOCT-based device is that they can acquire data in the mature cataracts and the white cataracts. It's not a problem. I personally compared IOL Master 700 and TOMI is much, much better than IOL Master 700 in white and in hypermature cataracts. This is a 2023 review of 4 different optical biometers, and their conclusion was very simple. The Argos was able to capture valid readings in all those very dense LOCS grade 3 cataracts and white cataracts, while the IOL Master and the Antirion came next, and the Pentacam could capture valid readings in only 2/3 of these eyes. The other advantage of the new generation optical biometers is they give you a lot of additional features which prevent us from making simple errors. For example, they have multiple checkpoints. So they will show you the K like this, and you know that the tear film is not good, and you have to ask the patient to blink, or you have to optimize the tear film before you do the surgery. This is one more patient. We're all scared about posterior polar cataracts, and we feel compelled to tell the patient you may need to have a vitrectomy. But with the newer quality biometers, is not necessary because they'll give you an image of the posterior cornea like this. So PPC with an intact, nice, smooth posterior cornea like that, you can go ahead with your routine careful surgery. You don't have to tell the patient you have a risk of PCR. If you have a posterior polar with a small bulge like this, then you may have to tell the patient that your lens is a little weak. This particular patient came from Tiruchi after multiple anti-VEGF injections with a white cataract. On slit lamp, I could not see this, but with the IOL Master 700, you can see a nice posterior capsular tear. So PCR pre-op picked up by the optometrist with an IOL Master 700. So they pick up these small problems which we tend to miss on clinical examination. This is one more patient with a very dense cataract, came for cataract surgery, had a small macular hole. So the newer biometers have these extra features which make your surgery easier. Now, we discussed extensively about which formula is best, and we have multiple AI-based formulas which are the future. There is no doubt about it. The pure AI or the Hill RBF, the Camara, and the Nallaswamy, and the Nallaswamy is from Kellogg University. The partial AI or the hybrid AI, where they have a basic theoretical model on which the AI refines it further. So there you have the Kane, Pearl DGS, Hoffer QST, LADA super formula. Full Monty website is currently not working. So this is a 2024 review of all the AI-based formula by Stoperia et al. And they found that many of these newer formulas have one or two or very few publications. But of those which have a number of publications which we can trust, Hill, RBF, Kane, and LADA's Pearl DGS, Kane is the best. So if you want to use one formula for all your regular patients, please use the online free, high-tech, low-cost Kane formula. Every formula is capable of improvement, and we have no idea which the best will be 1 or 2 years from now. So from Barrett, if possible, please switch over to Kane. When Kane cannot be used, in special situations, Kane cannot be used, for example, post-LASIK, or if you want to do an IOL exchange, please use the Barrett suite. There are multiple other machines. They all give you some extra information which may be useful in some patient. For example, this is a topographer from the OPD3. It tells you the pupil size in photopic and mesopic conditions. It also tells you how the astigmatism changes between photopic and mesopic conditions because of the irregular cornea. So in a patient with keratoconus, if you just take one measurement, you may think, okay, 2.38 cylinder, I'll put a toric lens. But when you see that when the pupil dilates, the cylinder and the axis totally changes, you will make a different decision. Expensive equipment, expensive maintenance. For example, this is the IOL Master 700, the cost before COVID, and today if you ask them, they'll list it at 40 lakhs. Now, this is fine. Most of us, we may be able to afford it. But a few months ago, the service engineer said that time is coming out wrong. We had to change the battery. And he came to change the battery. And then after 4 hours of effort, he said it is stuck to the motherboard. We had to change the motherboard also. So he changed the motherboard and gave a bill for 6.25 lakhs. For changing the battery of the motherboard of the IOL Master 700. So all this cost is future cost. It's not a one-time cost. And I think most of us after COVID feel that we should not get caught up in a situation like that. Our revenue streams have become uncertain. This is like, again, 2 weeks ago, from Bajaj Allianz, they have reduced somewhere about 12,000 and odd rupees from a cataract surgery. And you know the number of phone calls and the follow-up, we have no idea why they have done all this. So we are in a situation where revenue streams are uncertain and cost is going up. So think about this. So if we want to avoid all these health issues, it is better that you think twice and probably have a common center or have large groups to purchase this. Individual doctors, I think, may not be able to comfortably afford all this high technology. But the future is still very good. Wearable stimulators are there in the horizon. One example is a B-Vision project, which has not yet come to the market, but they are talking about this, where in the initial checkup, they will check your eye power and the aberration profile. Then they will use adaptive optics. Then they will simulate how this. Then you will wear a simulator like this, and you can walk around with this. And then you can put in an EDOF lens, a bifocal lens, a trifocal lens in that, a monovision. You can show the patient different options. Obviously not applicable. I think I have, time is up. So that's the future. Future is great. So please use low-cost, high-tech Kane formula for most of your patients. Thank you very much.
Thanks a lot, Ramesh, for your brilliant presentation.